nice words. So, first, to me, I'm Simon Berghammer. I'm from the Department of Rheumatology and Immunology. And in the last 2 months, I had the honor to train at the Department for Cardiology, the cardiac ultrasound. So let's get started. Does any one of you know this guy there? Okay, this is Clemens, and Clemens is the head of the cardiology ultrasound unit in Graz. And in this situation, he performed an ultrasound of the heart, and this is an emergency setting. So this patient we see there, so let's try it. Yeah, there's dyspnea and low blood pressure. So what do you do with low blood pressure? Maybe give them some fluid, but we don't know how is the status of the fluid. So what can you do with the sonographic of the heart? There are some cool things. So at first, it could be a ventricular thrombus or pericardial effusion or myocardial aneurysma. You can see it there. Aortic stenosis there. Left ventricular non-compaction, heart failure, PFO, you can see it there, yeah, and mitral regurgitation. So these pictures look very nice, or? And they're like on every video on YouTube or in textbooks, but the reality is maybe this. So can any one of you say, well, what is the left ventricular function there? Anyone? Me neither. So we have some things that could help us. The RUSH protocol. It's designed for an internal medicine emergency, and the aim is to assess the fluid status and the heart function. There are 3 main parts: the pump, the tank, and the pipes. So first the pump. The pump, you have the fuse of the parasternal long axis or the parasternal short axis, the 4-chamber view, or the subcostal flue. For the tank, the main thing you have is the vena cava inferior. And for the pipes, the aorta. So go on. We would start with one scenario. This really happens 2 weeks ago. So this patient was 56-year old. He came to the hospital with dyspnea. No medication, no medical history background. So the ECG was pathologic, and the NT-proBNP was was elevated, but the troponin T was slightly elevated. So what you do first? Yes, we performed an ultrasound. So can anyone say what we can see there? Maybe? Okay, we see there on the left, this is the parasternal long axis view, parasternal short axis, 4-chamber, subcostal. So we see there is a reduction of the left ventricular, So we could also see this there and there. So the patient got worse. He needs for implantation of a mechanical circulatory support system, the ECMO. And the etiology was still unclear. So we tried endomyocardial biopsy. Through this biopsy, his blood pressure went to 50 millimeter Hg systolic. So, okay, what could happen? Any ideas or anything you want? What is your next thing you want to do in this situation? Decreasing the blood pressure was during the biopsy? It was during the biopsy, yes. Yes, and which, what would you perform at next step to fix this diagnosis? Yeah, but at first you have to fix your diagnosis. So we performed the ultrasound as well. And you see there a pericard tamponade. So this is the pericard effusion there, this black one. And we tried to drain this blood there at the first step, but we went to the right ventricle. This is not good. You see this there. Yeah. But after this, we pulled back the drain and we could release 900 milliliter of blood. And this was the result after 2 hours. And now the patient felt well. We still didn't exactly know what is the cause of the cardiac shock, but he still feels better. He sits outside the bed and I think he watched the football match yesterday. Yes. Yeah. Okay. So, but go on with the fluid status. We still have the patient with dyspnea and low blood pressure. At first, we will have a look at the vena cava. The vena cava inferior is directly the right atrial pressure directly influences the inferior vena cava. So you can use the phased array or a curved array transducer from the subcostal view to assess the vena cava. There are some, we go to this a little bit later. Yeah, so you can see there. This one is the M mode of the vena cava. This one is normal, non-pathologic vena cava. This one is pathologic. You see there, the collapsibility of the vena cava there is more than 50% with the respiratory. And you see there, you see there, the vena cava is big, it's more than 21 millimeters, and there is no, so if I go back, there's no collapsibility. So maybe you have a higher right atrial pressure on this picture. Yeah. So there's some data about it. And this one there, the right atrial, the end inspirated diameter correlate with the right atrial pressure. And on this side, the collapsibility correlates with the right arterial pressure. On this slide, we have I think that the diameter of the vena cava inferior is a very good prognostic factor of heart failure. It's even better than the GLS, the global longitudinal strain, the EF, or the TAPSE, the right ventricle function. So there's a really good predictive value. So, any one of you know what this is? Any idea? There are no wrong answers. So just, okay, this is, okay, maybe the movement didn't, it should move maybe. Yeah, this is not a rush, but it's a part of it. This is the vena jugularis, and this is the carotid. This is the muscle. So you can pick a linear transducer and raise the position of the head to 45 degrees. And important is to avoid the compression because the vein is really easy to compress and use nothing there. You can measure with two methods, at first with the diameter or the M mode. So we go on. There you see a non-pathologic. So there is a really small diameter at first. Then you have to do the Valsalva maneuver. Everyone know the Valsalva maneuver? It's like the thing you do on the toilet. So, and after the Valsalva maneuver, the vena jugularis should got big. But if the vena jugularis is still, the diameter is still big in rest and just gets a little bit more with the Valsalva maneuver, maybe you have a congestion. So this is with the M mode. You have there the baseline, so this is the rest. Valsalva maneuver, you have more. They are the same, the baseline. With the Valsalva maneuver, you have this. So you can do some ratio. The baseline, you have 2 millimeters, Valsalva 12 millimeters. The ratio is there 6. There you have 9 millimeters at the start, and Valsalva is 70 millimeters. The ratio is 1.8. We have some data to this, so it's a really good value to show you if there is maybe a cause of a congestion. So if this ratio is under 4, you should think about the congestion. This is just about the vena jugularis. Okay, so go on with the rush protocol. We had the tank, we had the, what did we have? Tank, pipes, and the other one, okay, yeah. But now we have the pipes. So anyone, what do you see there? Pump was the other one, pump, tank, pipes, yeah. So there, any idea of this? This is a 5-chamber view. Okay, and you see here, okay, yeah, there, well, yeah. Severe acute aortic regurgitation. So if you have a patient with dyspnea, this could also be a cause of his dyspnea. So this is really massive, and I think he should go for a interventional surgery, maybe. So, and this one, any idea what this one is? It's there, okay, yeah. The section of the ascending aorta. There, the personal long axis view, and there is the short axis view. So, this was the rush, yeah? There, okay. So, there, this is the aortic valve, and there you have the aorta ascendens, and this is really big. It's really like a balloon, okay? And there you see the aortic wall, and this is the dissection there, okay? Yeah. So beyond the lung, the rush protocol, we have the lung ultrasound. Have you ever performed a lung ultrasound? They're really cool tool. So it's really easy to perform. You need no training, and you can use any ultrasound system. So there are some zones you should do it, but in practice, you could do it everywhere on the lung. Okay, this is just for studies or something like this. You can do it everywhere where lung is. You can do the lung ultrasound. What can you see there? The A lines. The A lines are artifacts from the pleura. They're horizontal lines, go from the top of the display to the bottom of the display, okay? They're normal, they should be there. But what not should be there, are B lines. B lines are for the interstitial syndrome. They're extravascular fluid inside the lung. And they arise from the pleura, they move on the breathing, and they reach the limit of the image. So I just know the German word. In the German literature, they say it's kometenschweifartig, from the top to the bottom. Yeah, you see that, and this is really, if you have a patient with dyspnea and B lines, maybe there is some extra fluid in the lung. Causes, yes. So congestion, we said it, heart failure, or pneumonia, or the acute respiratory distress syndrome. In some cases, the B lines do not appear. So in COPD, asthma, pulmonary embolism, pneumothorax, there are no B lines. There should not be B lines. So there is a study about it. There are 530 people, patients with heart failure and dyspnea, and they were split in 2 groups. One arm gets a lung ultrasound, and the other gets a chest X-ray and a measurement of NT-proBNP. And after this, we see that there are no difference for the diagnosis between the lung ultrasound arm and the chest X-ray and NT-proBNP arm. Even the lung ultrasound is a little bit better, so they're maybe equal. But the main is that the time for the chest X-ray and for the measurement of the NT-proBNP is about 1.5 hours, and the lung ultrasound is performed in 5 minutes. So it's really a cool tool. So the summary: how to in the acute setting. So I have a patient with dyspnea, and what you do first? Don't do first the ultrasound. Don't forget the basics. So ECG, lab, monitoring at first. Then you can start with the fluid status. We heard about it, the vena cava inferior diameter. Then at next one, the pump. Then the lung, don't forget of the lung. And at least, but the vena jugularis. So this you can perform it at the end. And then you have a real cool overview of the patient. So thank you for your attention. Any questions?
Anyone has any questions to the Rush protocol? Maybe back there, perfect.
Sorry, I don't know if it's just me, but what about the pipes now? You
Sorry?
do like
For the pipes, yeah.
Yeah, do you do like suprasternal view or like then check the abdominal aorta? Is there any dissection?
It's really difficult to check the abdominal aorta because the patient's not always like young, thin, sporty patient. Yeah.
Yeah, but just like check the carotids and like the arch if it's possible. From
It's not on the first thing. You can do it later on, but the main is the pump function of the heart, the fluid status, and maybe if you see in the personal long axis the aorta ascendens. Yeah, this you could. But
so the pipes are only in the long axis.
Yeah.
Yeah. Okay.
Yeah. For the emergency protocol, just do the view. Keep it simple. So you don't have enough time. Keep it simple, and you can do the rest afterwards.
Yeah. Okay. Thank you.
And well, anyone else has any questions? I think I have a question as well. Perfect, thank you. So it's more a common question.
Okay.
To move there. In your experience, what are some common challenges for healthcare professionals? What challenges do they face using sonography? And how can these challenges be overcome?
Okay.
And maybe because I know it's always like training, but can you go a little bit just...
For me, everything is challenging. So, okay, I'm a rheumatologist. So we don't use the ultrasound as often. So I had the chance to go for 2 months to the cardiology unit to perform and train the ultrasound. But I think the most important thing is to have one on your side to teach this. So you can see things, you do something wrong, he says, okay, that's wrong, do it the other side, or to put your hand like this and do this. And this is really, really important. So I had Ewald Kolesnik, and he was really cool, and he introduced me for really cool things. And it's really cool to have someone on your side. So this is the most important thing, I think, yeah. And training, yeah. It's training, do it, yeah. And grab every chance for a sonography. So just do it.
And like after how many echocardiographies did you feel like you were comfortable?
I don't feel comfortable.
Okay.
No. I did it. I think I have maybe 150 or so. And I think, okay, the basics are okay. But if there is some pathological feature, no. I think you have to do, for the cardiac sonography, you have to do 200s, 300s if you're really, comfortable there.
And did you start with like only patients where there are pathologies, or was it starting with a healthy? Like,
no, it was just, this was in the ambulance, so they have a pathology, maybe, they have,
So it's always like knowing, okay, maybe I'm gonna find something and I have to really look
and
out for it.
At first I always saw a pathology, and I've never saw a healthy person. So I just saw the valvular regurgitation and something like this, but not a healthy person. So it's really,
And maybe the last question from my side, how did you decide that you want to get deeper into echocardiography?
Yeah, so I'm a rheumatologist, become a rheumatologist, but I'm also a common internist. So I think I have to do some basic things. I don't want to go deep into the echocardiography, but some basics. I think everyone should learn some basic views about the cardiac sonography.
Okay, no, I still have like one last question after that. Because like right now we feel that, or at least in Sono for you, we feel that students get more and more proficient with ultrasound. Like especially over the last 2-3 years, we just realized at the late summer school that you guys are getting better and better every year. So what a few years back we still like really had to go into the basics, and now you're like really advancing. Or many of you are just at an advanced level. How was it with you in your studies, and kind of what touching points did you have with sonography?
At my Okay, I finished medical school 2015, and there was just one sonography course the whole study, and but there was Sono for You, but it was really, it was not easy to get into one of these courses. So yeah, but now I think the things is changing. So Professor Fickert is really doing a great job and tries to bring this sonography on a higher level. So just the importance is more. Yeah.
Perfect. Thank you.